Welcome. I'm very excited to have you all here for this webinar, Advancing Wellbeing Through Social Prescribing. Super excited about the topic, intrigued to learn myself today. As with most of our webinars, we're going to record it. We'll put it on our website for you to rewatch later today or first thing tomorrow, and we'll send an email out to let you know. If you have questions throughout the presentation, if you want to just put them in the chat, Alana and I will keep track of them, and we'll make some time to get some answers to those questions at the end. And we encourage questions. So please, if something's coming up, do let us know. And with that, honored to have our guests here today to talk about this really important topic. And I will hand it over. We'll hand it over to Julia Hotz, who can dive in and welcome everybody. And thank you again for being here.
Woo! All right. Thanks, Missy. Thanks to the Wellbeing Project for hosting us. Super excited to be here with you all. And even though it's late or early for some of you, I hope your minds are ready for some questions and for some serious learning. I hope you feel today the way I first felt when I heard about what social prescribing is for the first time. And before we dig in, just a little bit about who we are. My two guests today are some of the most humble people you could ever imagine. Their laundry list of accomplishments goes on and on, so I'll keep it super brief. But we've got Dr. Ardershir Hashmi here from the Cleveland Clinic. He, whenever someone says, okay, social prescribing, but like, are there any doctors actually doing this here in the United States? Dr. Hashmi is one of the first people I think of. He's so innovative and thoughtful with his approach, as you'll see in his slides today. And we also have the amazing Mr. Dan Morse, who is equally as thoughtful, innovative, creative. He is the person I think of when anyone asks, like, okay, social prescribing makes a lot of sense, but, you know, how do we get this into schools and the next generation of students? And how do we get it to more Dr. Hashmis? That's Dan, and he's got all the energy and creativity you could imagine it would take for that role. So he's going to talk a little bit about what the spread has looked like in the United States, as well as like, what is social prescribing, this thing that I keep mentioning but not defining. More on that. And as for me, I'm just the lucky journalist who's been a witness to this incredible movement. It's the thing I've been the most excited about in solutions journalism for a long time. So much so that I'm currently writing a book about it, which will be out next year. And hopefully, if there's time today, I'll get to tease a bit out at the end. But what's on deck for today? First, we're going to hear from Dan about what social prescribing is and what its spread has looked like in the United States, where it looks like the majority of us are from. Although for those outside the United States, you'll be happy to learn it's gained also a ton of momentum there as well. Then we'll hear from Dr. Hashmi about what it's looked like at the Cleveland Clinic where he practices. And if there's time at the end, I'll go into a few tips for how you can integrate the benefits of social prescribing in your own life through the stories of some of the people I've met on the road in reporting this book. So without further ado, I'm going to stop sharing my screen. Dan's going to start sharing his to talk to us about what actually is this thing, social prescribing, that I keep defining.
Thank you for the wonderful introduction, Jules. And we'll start off a little interactive. So I just dropped a link to a collaborative slide deck. So you should be able to come in here and edit something. Edit one of these little sticky notes, digital sticky notes. And the question I'd love for us to explore is, what matters to you? Could be in work, could be in life. Really, what is your genuine answer? Because it's going to kind of tie into our exploration of social prescribing together. And no, don't all put Dr. Hashmi's implementation of social prescribing. I know it matters to you. I know that we're all really eager to hear him talk, but you know, let's just get a little diversity in the answers. Friendship, work-life balance, connections. Peace. Ooh, that is a tasty one. On that side, it looks, Jules, it looks like we filtered the crowd for people who are really into this topic. Nicely.
Yeah, maybe they have some ideas about where we're going with it.
So I mean, I know you all are social innovators, so I'm not surprised that you're doing things that are so social and so humane. I'm going to kind of dip back into this topic of what matters to you in a bit, but I'll just say, you know, from a high level, there's a new movement happening in healthcare called social prescribing, and there's a lot of different organizations that have stakeholders working to make this happen, exploring making this happen, and you know, I'll talk a little bit about those. But to kind of set the stage, I first just want to share a story about is actually my experience as a kid when I grew up in New Jersey, like we were talking about earlier. I grew up right outside New York City. And when 9/11 happened, I was 10. And my dad, who's a clinical psychologist, decided that he was going to take 2 weeks off work, went to Ground Zero by himself, and just proactively started reaching out to firefighters and police officers to offer psychological counseling. And I remember being 10 years old and seeing him come back with this soot-filled NYPD hat. And, you know, he was at Ground Zero as smoke was pluming in the background. He'd come back to this soot-filled NYPD hat and really thinking, my dad is a hero. And it wasn't until a decade later that I realized it wasn't just my dad doing such a heroic effort. There were doctors giving their time, chefs, artists, construction workers, all kind of giving their time. And I think it's really fascinating when we hit times of crises, humanity really comes out to support each other. Yet the challenges of today, many of them are silent crises. We have 132 million people depressed. We have 100, spoiler alert. 32 million depressed, 192 million people lonely in the US, 100 million people obese, 20 million people addicted. And our pharmacological approaches to addressing these has these limits. We aren't effectively solving these challenges with pills and procedures alone. And so we need something else. And how can we address these as a society? What does the next generation solution look like? And at the same time, over the past 5 years, there's been some revolutionary research that's come out that kind of sets the stage for social prescribing. Think about the last time you were experiencing joy, last time you felt truly alive. Chances are you were with people or doing something you love. Over the past 5 years, there's been some research. There was a review of 3,000 studies by the World Health Organization showing that engaging in arts can improve physical and mental health. A study of 3,000 people at Harvard showed that you live longer if you volunteer. There are dozens of studies showing that nature, with as little as 10 minutes a day, can improve your health and well-being. And there's also a lot of studies showing that having a sense of purpose can improve your biomarkers across socioeconomic spectrum. So these flourishing activities are essential drivers of wellness. We also know that friendships and relationships are also a critical aspect of health. There's famous research showing that being heavily lonely is akin to smoking 15 cigarettes a day. And at the same time, we also know that if you really want to be healthy, the doctor can only help you so much. You also need to have your basic needs met: housing, food, enough resources. And so, you know, as this research is coming out, we're really looking at a new chapter, a new understanding of health that is emerging. And it starts with a simple idea, starts with a simple question. And that is, what if doctors prescribe more than just pills? What if they prescribed arts, nature, volunteering, social services, the very things that are emerging as new causes of health? And so this is what social prescribing is. I'm going to quickly play this 2-minute video that I think really outlines it nicely. Yeah.
Many things affect your health and well-being. GPs tell us that a lot of people visit them feeling isolated, lonely, or stressed out by work, money, and housing problems. These are issues that can't be fixed by doctors and medicine alone. At its most basic, a social prescription offers the kind of help that doesn't come in a tube or a bottle. The idea behind social prescribing is to help you to have more control over your healthcare and find ways to manage your needs in a way that suits you. There are lots of different ways of providing social prescribing services. It often starts with a conversation, perhaps with a link worker, a support broker, or a community navigator. Whatever they are called, they are there to listen to you and put you in touch with whatever it is you might need in order to feel better. That might mean being introduced to a community group, a new activity, or a local club. It could be legal advice, volunteers to help around the house. It might just be information and guidance, a bit of inside knowledge on your situation and what local resources there are available. It could even be some support in how to create something new. Studies show that individuals with social prescriptions get better and feel better faster than those treated with medicine alone. And because it works, it's happening more and more.
So I'll break it down kind of simply. So to break it down, the way social prescribing works is a patient goes to the doctor. Patient goes to the doctor and mentions they have moderate anxiety, loneliness, depression. And in our current system, a doctor will typically then prescribe medication or therapy. But many patients are either resistant to drugs, on too many, or looking for pharmacological alternatives. So instead, doctor will refer them to a link worker who can help find a personalized activity or resource in the area, also known as a social prescription. And let me ask you this. I'm asking all of you listening now. Think of your two friends who are the most different from each other. Okay, get them in mind. Most different from each other. Get them in your mind. Now, let me ask you a question. Would you get them the same birthday present? Let me see an emoji, if anyone wants to drop an emoji in or anything in the chat. Probably not, right? So similarly, not everyone gets the same social prescription. The way it works is that a link worker has a menu of 100, let's say 100 different local social prescriptions. So it might be a walking group in the park, 5 art classes, a theater, free theater troupe, a volunteering event that have that menu. And with the patient, they co-produce a social prescription to their interests. So for Ardershir, it might be engaging in arts because he loved arts as a kid and he kind of revives that joy. And for Jules, it might be hiking because Jules actually really likes being active. It's customized. Now, let me ask you another question. Do you know anyone or yourself who has struggled with anxiety and depression? And it looks like most people are not familiar with those terms. So, Google it, you'll learn a lot. But let me ask you another question. Put in the chat real quick if you think it's easier or harder to engage in activities and groups when you're depressed. Harder, much harder. I would say the correct answer is much, much, much harder. And so we know that when people are lonely and depressed, they're more reticent to connect with others. They need coaching to get over that hump and engage confidently. And a link worker can ask questions like, do you have any hesitations? And what could you do to ensure that you actually go? And patients are emerging out of depression with more agency, more confidence, and more tools to manage their own health. People are finding strength in community service, peace walking through pastures, calm and creative expression. Local community culture is enlivened with more relationships and activity. And the beautiful thing is that social groups have an incredible power to address loneliness and also reinforce positive health behavior. For example, if I wanted to exercise more, the number one thing that would actually get me to exercise would be if a friend knocks on my door at 7 in the morning and drags me to the gym. What if our solutions to our health were each other? What if health was not just found in pills, but in people, not in procedures, not only in procedures, but in pursuing purpose? not only in addressing what is wrong with us, but also building into what is right. And the amazing thing is that social prescribing is being scaled nationally in the UK and sprouting up in 23 different countries. You can go into any general practice doctor's office in England and get a social prescription. And the research is really, really powerful. Here's some of the research in the UK. There's a meta-analysis showing that social prescribing has a reduction in accidents and emergencies, reductions in primary care repeat usage, shows a positive return on investment in a lot of the studies, and also a whole slew of health benefits from self-esteem, confidence, mental health, positive mood, lots of health benefits and potential cost savings. And in Canada, they're finding reductions in loneliness, improved self-reported well-being. So lots of amazing stuff. And I'll say, I wanted to I know that you all are social innovators. So I started thinking like, how can I really get into like the social good that's created? Because there's a lot of different projects that happen. So I wanted to kind of outline what are the distinct benefits of social prescribing from the US. So the first one, like I mentioned, is to reinforce increase adherence to intervention. So like I mentioned before, if you want to go to the gym, a social group can reinforce that. Second thing I'll say is that it also provides pharmacological alternatives. So for people who are feeling bad and don't want to take drugs, they have new methods of self-care, arts, nature, volunteering. I'm realizing that this is a little bit repetitive, so I'll jump through. But I think the other exciting thing is helping to bridge social divides and bolster civic engagement, increase altruism. Imagine if there's 10 million more people involved in volunteering. What would that do to society? So I'd love to ask you all a question now. We'll do another one. How do you start a social movement for health? How would you start a social movement if you were to advance something like social prescribing? Adopt and talk about it to everyone nice. Educate, gather evidence. Awesome. These are great. So I'll share some of the challenges and opportunities we've had in our work. People are talking about evidence, adoption. There's a bit of a chicken and egg problem because we need evidence to drive adoption, but you also need adoption to create opportunities for research for evidence, right? Adoption creates public interest in use. Public interest in use allows you to recruit doctors and health systems. Public interest can also drive policy changes and funding, but evidence can shift to culture. So the question is, where do you start? And the way that we've been thinking about this is gather a network of thought leaders. We had a bunch of digital happy hours on topics of volunteering and health, nature and health, arts and health, exercise and health. And we partnered with incredible thought leaders like Jill Sankey and Stephen Post. We invited a cross-sector group of leaders and prospective health systems, funders, stakeholders. And the amazing thing is that attendees have gone on to co-host offshoot happy hours, city-based happy hours, health system adoption conversations, joining our newsletter and volunteering for the movement. So bringing together all the people in dialogue to say, how can we collaborate, especially since social prescribing is so cross-sector, has been something that's been helpful for us. Another thing has been having a community of practice. So we've only done a couple of meetings, but gathering the people who are adopting to unblock each other and support each other's efforts has been big. There's also been a college student club chapter program that started up at Columbia and Harvard. And these clubs have been really, really incredible and have helped propel the movement because many of these students end up interning for the organizations in the community of practice. We had a student intern with Ardershir. And also we're kind of hoping to coordinate research and get multi-site social prescribing studies because everyone's using the same metrics. And so at this point, advocates and implementers are sprouting up across the country. We have pilots of 35 therapists in Utah, Ardershir. There's bunch of folks in New York City doing different kinds of prescriptions. There's a drug rehab nonprofit in Arkansas that's doing social prescribing. There's a safety net hospital system in California doing social prescribing. So people are popping up around the country. I'm a little short on time. Contra Costa County, just north of Berkeley. And I see your question. Was going to say any ideas to advance the movement, but I think I'm a little bit over. So I'll just say it to close us out. Social prescribing helps us heal people. It gives people more tools for self-care, helps us heal society. Imagine 10 million more people volunteering, 10 million more people finding joy through art. And it also helps us heal culture. So thank you, everybody. And next up, I'll pass it to, am I passing it to Jules or am I passing it to Ardershir?
You could pass it to Ardershir, but I'll just say, see everyone, this is why I said, could you imagine any better leader for this USA movement than Dan Morse? Thank you, Dan, for getting us all excited and marinating on that question. I should have flagged at the beginning, by the way, if you do have questions, feel free to pop them in the chat, or hopefully we'll have a little time at the end to get into them. But in the meantime, let's hear from Ardershir about what this has looked like in his practice.
Hi, folks. You can see my slides, I hope. Thumbs up, yeah. So yep. You heard the formal introduction. I'll give you the informal introduction to me is I am the uber fan of Jules and Dan and their work. So they're definitely the Steve Jobs and the Steve Wozniak of this operation. And I admire greatly their vision and everything they've done. I think what Dan just described speaks for itself, right? So, so my journey in this, I'll start with the story and sort of say, part of the reason that you see a little bit of a, this is, by the way, not planned, this is sort of serendipitous, a little bit of a different dress code. As part of like the blazer and tie sort of effect that we have is part of what's been wrong with healthcare all along, right? So we have taken ourselves so seriously as healthcare practitioners and healthcare systems and structures, and perhaps we have stopped listening to our patients, who this all started for in the first place, right? So what about taking them seriously and putting them front and center? So you'll hear this as a recurrent theme as I describe some of this stuff. My personal journey actually started way before I was in my current role at the Cleveland Clinic. So as a clinician, you know, the first time that I met Dan, it dawned on me that some of the things that I'd been doing that had brought me the most joy as a practitioner was actually social prescribing, but I didn't know the term for it. So I'd been subconsciously, if you will, sort of unknowingly practicing it all along. And I'll describe one patient very briefly, which was very, kindly included by Rachel Chen, the Harvard student who you heard about, who has since now spearheading the national movement among students for social prescribing. And this was the tale of a 93-year-old lady who would come to our emergency room like 50 times before I realized what was truly going on, which Rachel very embarrassingly obviously includes in the blurb that you can see there. But it's true. I mean, we would do $1 million workup with this lady who was coming in with chest pain and throat pain, and everyone would think, oh my God, this is her heart. This is something to do with her blood vessels in her neck. And the interesting thing was that as soon as the EMTs, like the emergency medical personnel, would get to her home, she would start feeling better, right? And on the way to the ambulance, she would progressively feel better. By the time she was in the emergency room, she was like, the chest pain is gone, right? But we, again, taking ourselves, seriously and sort of wanting to make sure we'd do this $1 million workup 50 times for it to be negative each time. And so in getting to know her, right? So again, putting her in the center of this and listening to her story, 93 years of experience, right? And so she can teach us a thing or two. Turns out that she had been, before these 50 emergency room visits, like she had not been to the emergency room very often, and she was still in her, mid 80s at that time. She had a very close connection with her grandson. And her grandson knew that she had always been a great ballroom dancer. And when she couldn't ballroom dance anymore, she would go to these classes that her grandson would take her to and would clap along and enjoy and take it all in. And that was really a really fun thing that mattered most to her. And then, wouldn't you know it, her grandson graduated from high school and went off to college. And so her the link worker, if you will, in her life, just was not there anymore. And there was no one to take her. And so here she was all alone in her home, completely isolated, feeling lonely, feeling depressed. And she feared the worst. So any single thing that would happen, she would start to get these chest pains, throat pain, and then that would lead to this sort of cascade. And so then we worked with a geriatric navigator, case manager, to fill the shoes of her grandson and start taking her to the ballroom dancing again. Wouldn't you know it, all these emergency room visits just disappeared. They melted away. And there was no pill involved. There was no diagnostic workup involved. It was just as simple as that. So then fast forward, I moved to the Cleveland Clinic and I say, well, I've been doing this, but I know this works, but how do you fit this into a system, right? And the system, the description of that will feel like, we've been doing this for 100 years. In 2021, we celebrated that, centennial. We've gotten a global presence, and have a lot of people who are healthcare professionals who work for the organization. But if you really think about what is at the core of this healthcare, interaction, at the center of it should be patients and communities, but there's also the workforce and people like me who are trying to serve, payers, the market, and none of us are really talking to each other, right? So we've created this maze for patients. So if we zoom in to what I found at the Cleveland Clinic when I got there was the same maze that the patient had to go through to get to their doctor, right? And so no guidance there. And when they finally managed to navigate this maze to somehow miraculously get to their clinician, they were faced with the advent of the 20-minute visit, which all of us are familiar with. I'm familiar with as a patient myself, as a father to 2 daughters who I take to the pediatrician. And so those 20 minutes starts running, as we all know, from the moment you hit the exam room and all the way leading into when you're from the moment you're in the waiting room all the way to the exam room. And clinicians, have to move from patient to patient. So they feel forced to move from patient to patient and move patients along like a conveyor belt with a one-size-fits-all approach. When in fact, each one of those patients are unique. To Dan's point, you wouldn't prescribe the same social prescription to every one of them. And when they start running out of time, they panic, right? They're human. So they sort of say, well, I can only focus on 3 things today, but for the rest of the 10 things that you're talking about, let me throw a pill at it and hope that it will stick. And so pretty soon your patient is a walking, talking pharmacy. Or they refer to 10 different specialist colleagues who are in 10 different locations in the same health system, maybe even on the same electronic medical record, but who are not really talking to each other. So completely fragmented care and the patient buried under this weight of medications that are not helping them reach what their matters most is, because, we never really asked them. We never really took the time. We never had the time. And what is it doing to clinicians? They're burning out rapidly. 54% of physicians burning out, 88% saying moderately, severely stressed, 59% saying to their children, we wouldn't recommend that you go into this profession because of what we have made it. So this first part of this sounds like a confession because it is. It's how we have messed this up. But hopefully the silver linings that you'll see in Dan's work and Jules' work and social prescribing movement are how it could be different, and very easily so, right? And then the caregivers, that invisible isolated army, says the AARP, who continue to soldier on to help their loved one without any recognition, support, or guidance at great personal cost, both physical and financial, their own health, interdependent with the people that they're taking care of. And yet no other stakeholders that we saw in that maze, payers, providers, nobody pays any attention to it. Oh, of course, they'll have some network. We just assume that they have a network. My 93-year-old patient did not. And you saw what happened, right, in that story. And then you throw in this already pre-existing social isolation, and then you throw in the pandemic. And now so you have that social isolation, and you magnify it 10x. So the ageism of traditional healthcare structures is we have all these cognitive biases. Oh, we'll just connect with them with a virtual visit. Do they have electricity in their homes? Do they have basic internet? Do they know how to operate that computer, right? A lot of these people are older, but any age. Oh, they'll come in and get their testing done. We'll just, they probably have a car. They'll just drive through. These are our cognitive biases that we don't challenge. Visitation policies, very well intentioned, but suddenly that person who was isolated is now not only fearing COVID, they have it, but they're in the hospital setting. Nobody can visit them from their family if they have anyone in terms of social connections. And the people who are coming to that room are coming in with masks and face shields. Even more scary, right? So no lip reading if you have hearing impairment, and that's how people have communicated that you've sort of tried to lip read, you can't do that anymore. Fortunately, there is light at the end of the tunnel, all the way at the very top. So our U.S. Surgeon General, Vivek Murthy, we had the chance to meet with him recently, and I know that Dan has done a lot of work with him, believes in this, right? So has written a book together, The Healing Power of Human Connection in a Sometimes Lonely World, and has taken a leaf out of the research that Dan shared with you, more dangerous loneliness than 15 cigarettes a day. So now let's zoom in again. What's happening at the Cleveland Clinic in the next 10 minutes or so? So we sort of said, look, we're hearing that from all of our patients and their family members. Let's ask them. We formed a patient family advisory council. We said, you guys build, what do you want to see that's different? How are we messing up? How can we solve this? And they said, well, we want to see all of you in one place, not at 10 different places. We want you to be co-located, and we need a team of people that are asking us what matters most to us. We want to connect with our grandchildren, right? How can you make my health better so I can just do that? But I need time to tell you that. So I want you all to get together and have this long 90-minute visit where I'll come, I'll bring my, loved ones, my significant others, and just work with us, have a working session. So the Successful Aging program is what came out of it. Clinically, we put what matters most at the center of it, but it helps us, get people to mental sharpness, a state of mobility, physical robustness, so they can do what matters most to them. And without medication, that alternate route. So you're decreasing the number of medications, but you are replacing it with other things, right? So that we work with the IHI, the Institute of Healthcare Improvement. That's what input is made as an age-friendly health system. But at the heart of it is reimagining, right? So when we're in these sort of sessions, we are one member of a much larger team, which includes the nutritionist, which includes people like Ann Basting, who's a PhD and a MacArthur Fellow, Genius Grant recipient. But she's gone through this with her mother with severe dementia. And she said she has a story to tell. Other people were suffering from dementia. Through that, there's a lot of healing. If I reminisce with her about the journey that she's had, look at the joy that this brings back into her life. Look at the spark that it brings into her eyes. How my mom comes alive again. And she has shared this with a toolkit that she's developed. The Alzheimer's Association giving people caregiver support. Social Determinants of Health, our non-for-profit allies, and Benjamin Rose Institute, Aging, Western Reserve, Area Agency in Aging, bringing this food, groceries, what have you, to people's homes. But we had to go beyond that, right? So we had to think really even, how can we make this no cost to our patients? So very fortunate partnership as fostered by Dan, Holden Arboretum, jewel in the crown for, the Cleveland area. We were talking about this earlier about the metro parks. Free access to patients and caregivers as a pilot, 150 people, we'll see what happens. We're collecting this data anyway about depression, loneliness, memory loss at every visit. Does it get better when we go away from the medications and connect people to what they really actually want to do when we ask them? Arts and medicine, same thing. Does art therapy, music therapy work? How can we bring it into the patient's visit? How can we continue it when they go home? The Karen L. Farrell Foundation, another partner on that same platform. So they're part of this team that meet with them. People with advanced dementia, you give them artwork to do, the creativity that it sparks, the amazing artwork that they come up with, and the therapeutic effect that has. But how do you find those pockets, those areas where, these folks who are isolated, who need not only the 4M clinical care, but the social determinant and social isolation, the social prescribing. Here, technology comes to our, advantage. So there's an area deprivation index, as kindly fostered by Dr. Amy Kind, which can navigate by zip code what are the areas of the greatest social determinant need. We worked with our analysts to superimpose on that what are the areas of clinical need. And so we can do that now. We can sort of not only identify in what zip codes is the greatest need, but who are the people who are living there? What matters most to them? And how can we actively reach out to them? Now you might think, well, great, you've identified who these people are, you'll just reach out to them and hey presto. So I'm incorporating a lot of the lessons that we've learned along the way. But it turns out that that is easier said than done. So it's what I refer to as a Swiss cheese model from referral. I did a social prescription today to the fact that they're actually doing it, implementation. There's a lot of people who fall through the cracks. And so we responded to that by going low tech and high tech, right? So low tech, one of our geriatricians, Ken Concilia, at the height of the pandemic said, he found a bunch of trainees, 90 medical students that he's responsible for. And he said, look, you guys can't come to class anymore because everyone is locked down. But you do have the traditional landline and you can reach out to people and we know where they are. So in 3 months, they reached out to 4,000 vulnerable homebound elder adults and they just asked them, what matters most to you in this situation? How can we get you the care that you need? Working with all the community partners that I mentioned. And in doing so, they were learning, right? So they were these trainees who were like, wow, this feels really good. Why does it feel so good? We've never been taught this in a traditional curriculum. So it was a new curriculum for them, but it was introducing social prescribing to them because they are the future. They can reimagine, they can do better than what I have done, right? And how we've messed it up. And then high tech. So Unite as an Illusion is an electronic platform which a lot of community organizations have now joined. So at the point of care, when I'm seeing a patient, I could go into my electronic medical record and go on this platform, and there are all these organizations that have joined, and I can just, with a click of a button, connect with them so that they will now reach out, right, and magnify the impact of this. So 1,250 users, 222 organizations, almost 500 programs, 30 new organizations as 2022 alone. So this is something that is spreading. Why? Because we're trying to simplify as much as we can, and we're doing what hopefully we'll be doing, for the latter half of this, sort of with Jules' help, is how can you bring this into your own life, and how can we listen to you? So we're here for, to learn and for you to help us as much as to share what little we've been able to do so far. So last thing that I'll say is that there are some national movements like Patient Priorities Care. This is a movement out of Yale that sort of said, wait a minute, all these quality metrics that the physicians are held accountable to, instead of all of those, we should be taking this from you need this treatment for this disease to knowing your health conditions, your overall health, and specifically what matters most to you. I suggest we try this. So when I heard this, I was like, you know what this is going to lead to? This is going to lead to that person's matters most and a perfect segue into social prescribing. Because the person is telling us, this is the thing that matters to me. You work on all these other 3 M's, but it has to get me to the thing that is going to bring joy into my life. Mm-hmm. And so this works. It's an increased focus on patient goals. There are less medications. There is less treatment burden. But interestingly, the Patient Priorities Care movement, they had never heard of social prescribing. And so they're doing it. But our job now is to bring all these like-minded people together to just sort of really bring to life what you and I know has worked and has worked for a long time. So I will stop there, stop sharing my screen, and invite Jules to take us.
Wow. Dr. Hashmi, thank you so much. Just as, Dan is the perfect person to be leading the movement, I can think of no one more dedicated and thoughtful than Dr. Hashmi to be thinking about that Swiss cheese, like all of the many, many things that make up healthcare that make this go from great idea to like actually practice and priority. I'm so grateful Dr. Hashmi is in this movement, had success at spreading it at Cleveland Clinic and beyond, and is thinking about these questions of how do we build this into our system. So we'll end today really, really quickly because we do want to leave a little bit of time for your questions is what we can do in the meantime, right? Part of the goal of Dan's organization, Social Prescribing USA, of which, Dr. Hashmi is at the heart of, is to like actually get this in offices, healthcare offices around the country, so that by 2035, social prescribing will be as prescribable and something we talk about, as easily as we do with other types of medications. But in the meantime, I've spent the last year, as I mentioned at the beginning, writing this book about what can we learn from the places and the people who have already received social prescriptions. And you'll have to read the book to find out, but just to tease a little bit of that, the way that I reported it was across these 5 core categories. What does it look like when doctors and health workers prescribe us some form of movement? What does it look like when doctors and health workers actually prescribe us some form of nature? What sorts of mental health concerns does it help with? And these are just, 5, but as Dan said, just like there are infinite birthday presents, there are infinite kinds of social prescriptions depending on what matters to the patient and what the community has available. So to show you what I mean by that, I want to tell you the story of, why isn't this working? Of a woman I'd met named Amanda. Amanda is this bright-eyed, very curious researcher, loved playing outside as a kid, was always exploring. And at the start of COVID, she was diagnosed with major depressive disorder after she had had what she describes 5 of the worst things that could happen to her. Number 1, she finds out her husband's having an affair. He leaves her. She has to move to a new place by herself where she doesn't know anybody. Her mom passes away. COVID happens and she loses her job. So she is extremely depressed. She described that time to me as feeling like she was enclosed in a helmet. Now, Amanda also lives in England, where social prescribing is a bit more nationally funded and developed. And after she goes to the doctor, who then connects her with a link worker, that link worker connects her with this sea swimming course put on by this local organization called Chill Therapy. And when I went to meet Amanda and her fellow Chill Therapy swimmers in the dead of September, which is pretty cold if you're in England, I met, as Dan said, a group of these passionate swimmers who've since become Amanda's best friends. In her time in the course, she's gone from being on the maximum dose of antidepressants to the minimum dose of antidepressants. She'd gone from having some of the darkest thoughts a person can have to no longer having those dark thoughts. She said, my life has become bright again. This course has helped me to clarify my mind and stop all the bad thoughts. So, and Amanda's not alone. A lot of the literature says that exercise and sea swimming in particular can be very effective for people who have depression. But I think most of all, it helped Amanda see, I'm not just my depression. I am this person who loves to explore, who has friends, and I just had these things happen to me. But through my social prescription, I was able to see beyond that diagnosis. Now, one other quick story I'll tell you about with the time we have left is about nature. Nature is another huge area in which social prescriptions are made. And since the 1980s, but really for much longer, we've known that nature is extremely good for our health. These researchers in the 1980s, the Kaplans, put forth this theory that says being in nature is actually one of the few things that restores our attention, right? We have so many things, video games and neon lights and screens and, the news taking away our attention. Being in nature actually restores it. And this guy you see on the right here, that's Dr. Ching Lee from Japan, who also in the 1980s, when they were having an epidemic of stress and heart disease, was one of the first doctors to say, let's connect the two. We kind of know intuitively that nature relaxes us, helps us feel less stressed, but let's send stressed patients out into the forest. Some of you might know this term. It's called Shinrin-yoku, forest bathing. Now, since then, I've met with some of the people who've been prescribed nature prescriptions for disorders of attention, things like ADHD, addictions, you might say, is something that interferes with your attention, post-traumatic stress disorder, in the way that it can leave you with intrusive thoughts and interfere with your daily life. So I met a gentleman named Nick, who is my age, 29 years old, who had been struggling with some of these things and was given a fishing prescription with a local group called Tackling Minds, actually started by someone who was struggling with alcoholism and addiction. And since then, Nick, among others I met with, he's improved his focus, improved his social relationships. Others I'd met with had been struggled with alcohol addiction. They're sober now. And as with Amanda, they've moved beyond their diagnosis. They say that, this just gives me time to think. It's helped me meet people who've become like a family. It helps me relax. It helps me get out of the house. And, I use the example of Nick, who's 29 years old, is probably not someone who'd be on a Wellbeing Project webinar, because he told me, it's not like he'd considered himself someone who'd necessarily been struggling with a mental illness. He didn't like to talk about his problems, but that was the beauty of his social prescription of fishing, where you don't have to talk. You just sit by the river and fish and engage how you want to. Okay, now, last who I'll mention if there's time, is the way that art prescriptions can help us. You might be thinking, swimming's nice, nature's nice, but outdoors isn't really for me. Well, this is where prescriptions around art can be really, really helpful. Some of you might know the field of art therapy. It's been around since the 1940s, applied particularly to people who've had a traumatic experience. It was first sort of tested among veterans from World War II. And when I met with a woman named Kuhn in Australia, that was exactly her situation. She'd experienced childhood trauma and abuse. She was out of work on what Australia calls psychological injury. And she tells me, I was lacking confidence. She felt like she couldn't move on from this experience. And even if she tried to do something fun, she just kept hearing what she called her inner critic. But she did love creating art as a kid. She just didn't get to do it a whole lot. And through this organization called Makeshift, Kuhn was able to get in touch with that inner child again. She learned how to use art as a place to express her feelings, which were not always, angry and sad, but also happy and joyful and hopeful. Since then, Kuhn has improved her relationships. She has more joy in her life. She's back to work. And she told me, I thought I was so broken and damaged, but I've realized there's more out there that I can do. So I want to leave about 10 minutes or so for questions. But these are just, a small handful of the stories that I've seen through social prescribing. And through the book, which will come out next year, spring 2024, you'll be able to read more about these people and dozens of others. But I think what's also important to know, especially here in the United States, or if you're in a country where you're like, we've never heard of social prescribing, we definitely do not have this, that there actually are a lot of organizations that have been around, will continue to be around, that are trying to address these 5 core areas of healing, even without a formal social prescription. Some of them might be walking groups, running groups, groups that, connect us with volunteer organizations, groups that help us with gardening. And I'm happy to put a link to some of these in the chat or in a follow-up email. But, I just wanted to drive the point home that if you're leaving this webinar thinking, this is so great and I want it right now. And in addition to, following the great work of Dan and Ardershir and talking to your doctor about social prescribing, there probably is something available in your community or also virtually if, accessibility is an issue for you. So with that, I think we wanted to leave the last 10 minutes or so for some questions, if there are any from the audience. And just a big thank you again to all of you for your enthusiasm and engagement. And, this whole movement is based on social relationships. And I hope that you see yourselves as allies as taking this forward and making it, part of a mainstay in healthcare for the future.
Thank you, Julia. Thank you, Dan. Thank you, Ardershir. Just looking at the chat, I know, Ardershir, you answered it via text, but perhaps you want to go a little bit more into the question about how much do these 5 areas rely on the component of actual connection with other people?
Yeah, I think it's at the core of it, as you're seeing from everyone, we quoted the U.S. Surgeon General, but, this is humanity, right? We have been resilient through a lot over the last several years. Why, how, what was under the most stress? Yes, our health, but our health at the core of it was not being able to do that, not being able to connect. So I think that is incredibly therapeutic, and all the examples that Julia and Dan have shared, I'll bring them into sort of, if you wanted to add anything, guys, about that, but I think it's absolutely key, to every single domain that Julia has talked about.
Yeah, totally. Yeah, that's a great question. I think, as Dan said, people have different levels of introversion, extroversion. People have different levels of where they're at in terms of their healing journey. So I've also met with patients, for example, who were given a social prescription and said, I'm really scared to meet other people. I'm nervous. And so in that case, the link worker went with them to the social prescription. So they knew that they would have a friend there. They knew they would have someone there that could make that connection a little bit easier. But I think for so many of these people, yes, it's not just the activity. The activity is kind of like the shiny box. It comes in and may have some healing properties on their own. But as you read the stories, you understand that it's the relationships with others they meet in the social prescription, and it's the relationships they're able to improve in their own lives through this prescription.
Thank you, Julia. And now I know you put it in the text, but maybe you want to plug your book. That's a question that has come up.
I'm happy to plug it again. It's called The Social Prescription, and it's going to be published by Simon & Schuster next year, but will be available for pre-order later this year. I also want to plug the great websites and works of my 2 guests today. Social Prescribing USA is a place where you can come to learn about the research, the community of practice. Dan, I don't know if you want to say a little bit more about that.
No, I think that's it. We have a newsletter that comes out every 2 or 3 months, and it's a pretty unique newsletter because basically we're just crowdsourcing insights about social prescribing from people who are practicing. So it's not like it's basically insights and shout outs. And if you fill out the form on the website and say there's a little bit about giving a background to you, and if you're interested in kind of diving deeper into social prescribing, it's often likely that if you're like, I'm a geriatrician, or I'm a community organizer, I'm a arts innovator, and you say like what you're curious about, I can often connect people to resources. So, if there's a geriatrician signs up, I send them to Ardershir, and then they're kind of building a network too. So that's all I'll say.
That's great. And we will build out a resource page on this topic on our website as well. And appreciate Julia has offered to help me with that. So hopefully we'll have more of that. And I would certainly welcome all of you back for another conversation, greater detail as information comes back. And as we learn more, and we can help with your movement. So we really appreciate that. If there's any other questions, and also feel free to take yourself off mute and ask them if you'd like. Okay, so with that, I want to thank you again for coming to participate. Thank you for hosting us and educating us on the topic. We have recorded the webinar, and it will be on our website, and we'll make sure we send it out, a link out to all of you as well, so you can watch it again. But we are very grateful. And like we do with most of our webinars, if you don't mind taking yourself off camera as you say goodbye, we would love to see who we've been talking to.
You're right, Missy. They are a really beautiful group of people.
Very beautiful. Everybody needs to be on camera.
Great. Thank you. And thank you so much, Missy and Alana, for having us. I mean, we love the Wellbeing Project. It's been so great to see so many people from all over the world here united in that mission. So we hope to see you all again. And thank you again so much.